Have you heard the saying, every system is perfectly designed to get the results it gets? Don Berwick coined that, and I was lucky enough to see him speak at UT Southwestern for the internal medicine grand rounds last week. I want to share his key messages and reflect with you about the role of informatics in what was his title, Rescuing American Healthcare. He said there are two ways to improve healthcare, try harder or change. The solutions offered, even today, are still largely focused on trying harder, but that won't work. If you yell at your car to go faster than it was designed to go, or promise it an incentive program, it still can't go faster than it was built for. So healthcare has to change. He started the Institute for Healthcare Improvement in 1991, which is committed to redesigning healthcare into a system without errors, waste, delays, or unsustainable costs. He's a co-host of the Turn on the Lights podcast that my daughter and I listen to regularly. Dr. Berwick said that the quality movement started with focused projects, such as getting central line infections to zero. I spent the first 10 years of my career in Pittsburgh. They were among the very first healthcare places to successfully migrate Toyota production methods into a medical environment, which they used for central line infections and other important projects. In this landmark study done at Allegheny General Hospital, where the pit is set, they show that these infections are not an inevitable product of complex ICU care, but the result of highly variable and therefore unreliable care delivery that predisposes to infection. In 2006, the idea of quality began to broaden beyond individual projects. Dr. Berwick was the first author on a publication describing what he called the triple aim. You may have heard of it. This demonstrated a maturation of the field that called for simultaneously improving population health, improving the patient experience of care, and reducing per capita cost. In his talk, he played a video of a flash mob in Nuremberg, where one by one, people came onto the plaza and played Beethoven's Ode to Joy. To him, this illustrates everything that healthcare needs to know to transform. It's an illustration of a system with a common goal, a unifying score, a servant leader, and a team where everyone matters. What if healthcare was like that, he asked. I reflected after his talk about the role of informatics in his vision of great care. You won't be surprised that I think it's a key element. The flash mob had a common goal and a unifying score that everyone was playing from. It reminded me of Alan Morris from Intermountain Healthcare, whose career was dedicated to decreasing unwarranted variation in care. Individual clinical decision-making may occur in the context of a common goal, but it often lacks a unifying score. Instead, it commonly exhibits mindless or unwarranted variation, deviations from best practice that aren't based on evidence or patient preference, and they're associated with waste, morbidity, and mortality. How do we reduce unwarranted variation in care? We need a unifying score that everyone plays from. In healthcare, that score is the knowledge of what's best to do when. Chuck Friedman is a champion of learning health systems. He recruited Brian and me to the University of Pittsburgh. Knowledge is the keystone that holds the learning health system together, he says. But there's a huge gap in translating knowledge to practice. Knowledge is most often represented in ways that humans can consume it, words, pictures, equations. But to create a unifying script, we need computable knowledge, knowledge that a computer can implement. I'll share an example of this from Alan Morris's career. Knowledge is often stored in clinical guidelines that say things like this guideline for patients on mechanical ventilation because of acute respiratory distress syndrome, or ARDS. Use the least positive end expiratory pressure and tidal volume necessary to achieve acceptable gas exchange while avoiding tidal collapse and reopening of unstable lung units. This is a unifying script, but with words like least and acceptable, it can lead to many different specific interventions by different clinicians or even by the same clinician at different times because it lacks the detail required for replicable clinical action. Alan worked with critical care specialists to create a replicable script that specifies precise decision points, like if the oxygen saturation is less than 50% and the fraction of inspired oxygen is less than 1, then increase the fraction of expired oxygen by 0.2. That's a guideline that's not only more easily replicated by a human, but can be implemented by a computer, in this case to adjust the mechanical ventilation. How did it work? Well, when other hospitals showed a survival rate for ARDS patients at about 10%, Alan showed that Intermountain survival rate was 40%. Computable knowledge resulted in decreasing variation that wasn't driven by evidence and that improved outcomes. Returning to Dr. Berwick's message, a system view of quality in today's world requires computable knowledge that can not only be applied in one place, but shared in the way that libraries have shared knowledge through books and journals. Computable knowledge is one ingredient needed to rescue American healthcare. If you're interested in this, there's an online conference in just a few weeks. We're enjoying the long Dallas summer at our house, especially Gorm and Shy, who cool off in the pool whenever they can. You won't catch Kari swimming. He likes to cool off in a different way.